My name is Antonio Di Meglio. I'm a medical oncologist and physician scientist at Gustave Roussy, based in Paris, France. I work in a cancer survivorship program focused on mainly the prediction of late and long-term effects of breast cancer and its treatment, and in general of cancer. So what I do is I try to use data to understand what patients are more at risk of particular outcomes over the course of their cancer trajectories, and so inform pathways of care that can be adapted accordingly. So the context and background of this study is that many women during and after breast cancer experience feelings of worry, particularly concerning their health or the future, or fear of cancer recurrence once their cancer has been cured. So we used the data from a large prospective multi-institutional cohort in France, the CANTO cohort, the cancer toxicity cohort, that was based in 2012, established in 2012, to collect data about long-term toxicities of cancer and trying to address these issues by predicting toxicities and then informing interventions. So included patients that were either pre or post-menopausal in this analysis, trying to understand patterns and longitudinal trajectories of worry. Participants completed survey using the Impact of Cancer Questionnaire version 2, 3 to 6 months after the end of primary treatment for breast cancer, so either surgery, chemotherapy, or radiation therapy, whatever came last, and then approximately yearly during 5 years after the completion of primary treatment. We performed group-based trajectory modeling, trying to understand how patients group into different patterns of multidimensional worry. And we were specifically focusing on the negative impact of cancer and the worry subscale of this questionnaire that assess various concerns about future, health, symptoms triggering fear of cancer recurrence. Analyses were stratified by age, so among patients that were 50 years or younger and 50 years or older. So we included approximately 2,300 women in the group that were 50 years or younger, and 5,300 women in the group that were older than 50 years of age. We found a great heterogeneity in the developmental patterns of multidimensional worry during and after breast cancer, meaning that there were at least 5 groups of worry, very low, high, or very high, and 2 groups with changing symptoms over time. There were among younger patients about 20% with improving feelings of worry. So feelings that were higher at the moment of completion of primary treatment and that progressively reduced over time. However, there were 7% of women in this group with persistently deteriorating feelings of worry, reaching their peak at year 6 after completion of, year 5 after completion of primary treatment. The patterns among older women were similar, although these women scored overall lower in these questionnaires, meaning that their impact in terms of worry was lower and more moderate. And particularly the group with worsening symptoms had only slightly worsening symptoms. We then went on trying to understand factors associated with membership to these trajectory groups, and found that there were differential factors among younger versus older women. Younger women were particularly concerned about their relationship impact, and partnered women were more likely to belong to trajectory groups with worsening symptoms of worry compared to low symptoms of worry, whereas older women had more associations with treatment-related variables such as receiving chemotherapy. Both groups, in terms of age, were strongly associated with baseline measures of depression and anxiety before the initiation of treatment. In addition, there were important impact on quality of life. Women with persisting and deteriorating symptoms of worry also had lower functional and worse symptom domains in a number of health-related quality of life questionnaires that they answered. Based on studies that we had previously performed using the same cohort, we would expect that there is great heterogeneity in the patterns of evolution of symptoms. Not all patients are impacted in the same way by the experience of cancer and cancer treatment, and some of them are particularly fragile when it comes to persistent symptoms or symptoms that deteriorate over time. Last year in this meeting, we presented data regarding a study focused on depression trajectories during and after breast cancer. And we also were able to find a group of women, about 20%, with deteriorating symptoms of depression. And this means that the symptom may not be present at the moment of diagnosis, but can be triggered by treatment and can persist over time due to a number of reasons. So I think the clinical implication of this study that we present this year, as well as other studies that we had previously presented, is that we really need to screen women that are undergoing treatment for breast cancer and continue the screening throughout the treatment phase and post-treatment phase, because symptoms can change and each patient may react differently. The most important part of this research is that it can inform risk-stratified pathways and interventions. So once we have identified the patients that are more prone to develop persistent or very impactful symptoms, we can address them very early for therapeutic interventions. And by interventions, I mean psychological support or all those interventions that can mitigate feelings of anxiety or depression or in general emotional distress during and after breast cancer. Resources are limited. The uptake of these interventions in the standard of care is often limited due to stigma associated with this type of psychological support, but also to lack of resources, lack of reimbursement from healthcare authorities, but also because of lack of knowledge by the physicians and healthcare professionals regarding the importance of addressing these symptoms. So I hope these type of studies that are just observational can inform intervention, but also raise awareness about the problem. I am primarily a breast oncology by training, and my profession is mostly focused on the treatment of patients with breast cancer throughout the spectrum. So I am particularly interested in presentations of the new data concerning breast cancer. And this year we have seen quite some new and important data that will impact clinical practice in this space. Yesterday we had the presentation for metastatic breast cancer, and we're looking forward to tomorrow's presentation about the early breast cancer space. I'm also very interested in supportive care, of course, and symptom management, and we have beautiful presentations, particularly regarding the importance of interventions that can address not only symptoms but also impact clinical outcomes. Outside of the breast space, there will be an important study on physical activity interventions and associations with clinical outcomes in the colon cancer field, so I'm also looking forward to that one too.